You know how it is, you're trying to get a handle on some complex health info, and it's easy to get lost in the weeds, right?
Oh, absolutely.
But you want to be informed. Well, you've come to the right place, because today we're taking a deep dive into a topic that's super relevant to a lot of folks.
Okay, I'm intrigued. What are we diving into?
STI-related genital ulcers. And we're going straight to a solid source.
Oh, okay, lay it on me.
The Ghana Standard Treatment Guidelines.
The guidelines, huh? Those are pretty comprehensive.
Yeah, they cover everything from what causes these ulcers to, how they're diagnosed and treated.
So what's the mission for our deep dive today? What are we hoping to pull out of this?
We're going to try to extract the actionable insights, right, so that you can really understand this health issue.
Makes sense. So where do we even start with something like this?
Well, right off the bat, the guidelines actually identify 4 main conditions that usually lead to these ulcers.
Oh, interesting. Okay. Which ones?
Herpes simplex.
Okay, sure.
Treponema pallidum.
Which is, most people know it as syphilis.
Exactly. Haemophilus ducreyi.
The cause of chancroid.
Yeah, and Calamidobacterium granulomatic.
Granuloma inguinale, yeah.
It's a mouthful.
It is a mouthful. And it's really interesting to think about how the prevalence of these things can really vary depending on, where you are geographically, even within certain populations. So the fact that these are the 4 that the Ghanaian guidelines focus on probably says something about, the particular needs and the landscape that they're addressing.
Yeah, that makes sense. Okay, so we've got our 4 main players here, but what about the person who might actually be experiencing one of these?
Right.
What are the signs? What are the things that they should be looking for?
Well, according to the guidelines, there are a few key things. I mean, obviously, the most obvious one is going to be a genital ulcer.
Right.
But here's where it gets interesting. They specifically say that this ulcer could be painful.
Okay.
Or painless.
Okay.
And that in itself can be a really important clue early on, You might also see some urethral discharge and some inguinal swelling, which is basically the lymph nodes in the groin.
So the fact that the ulcer might not hurt, that's significant?
Absolutely. Because that can really point you in a certain direction in terms of what might be causing it. Mm-hmm. And then when you actually look at the specific signs of each of these conditions, that's where the distinctions get even clearer.
Okay.
So for example, with herpes simplex, the guidelines describe the signs as multiple recurrent vesicular lesions. So, think like small fluid-filled blisters.
Okay.
That tend to, come back. Right. So that recurring nature is a real hallmark.
Yeah, and I think a lot of people know that about herpes.
Right.
How it can, flare up and then go away and then come back.
Yeah.
Okay, so what about syphilitic ulcers? What should we be looking for there?
So syphilitic ulcers, or what they call chancres in the early stages, they have some pretty distinctive features. They're typically described as being single, painless, and indurated, which basically means that they feel firm to the touch.
Oh.
They often have like a clear base and really well-defined edges. However, it's important to note that the guidelines do mention that sometimes there can be multiple ulcers.
Okay.
And they can actually be painful.
Okay.
And they might not have that firm feel, or they might have a purulent base, meaning they're filled with pus.
So not always that classic picture that we have in our minds.
Exactly. And then, in addition to the ulcer, there's often this accompanying inguinal lymphadenopathy. So, that swelling in the lymph nodes in the groin.
Right.
And they specify that it's usually discrete, meaning like the nodes feel separate, they're firm, they're painless.
Yeah.
And it usually appears about a week after the initial ulcer.
Interesting.
Another really key thing with primary syphilis is that the ulcer usually heals on its own within about 6 weeks, and often without even leaving a scar.
That's surprising.
Yeah, I know. It's really interesting. And so, it makes you wonder, does that sometimes lead to people delaying medical attention?
Oh, for sure. I bet it does.
Yeah.
Because it goes away and they think, oh, I'm fine. But it doesn't mean the infection's gone.
Exactly. So it's just on to the next stage.
Right. Okay, let's talk about chancroid. How are those ulcers different?
So chancroid ulcers, they're described as being quite distinct. They're painful with undermined, like, ragged edges.
Okay.
So imagine the edges look kind of eaten away, irregular.
Right.
The base of the ulcer is usually covered with this purulent exudate.
More pus.
More pus, exactly. And it bleeds really easily if you touch it.
Oh, wow.
The guidelines also mention that several of these ulcers can sometimes merge together to form what they call serpiginous lesions.
What's that?
Which have this kind of snake-like or winding appearance.
Ooh.
The lymphadenopathy that you see with champroid is usually unilateral, meaning it's only on one side.
Oh, okay.
And it can become what's called fluctuant.
Fluctuant, what does that mean?
It means that it feels soft and compressible, like there's fluid inside, which in this case, it's indicating that there's pus in the lymph node.
Oh, so painful, ragged, bleeds easily.
Right.
Pus-filled lymph nodes potentially on one side.
Yep.
So very different than syphilis, which can be kind of silent.
Absolutely.
Okay, and then the last one was granuloma inguinale.
Right.
What about that?
So this one has its own particular way of developing. It usually starts as a small papule, so think like a tiny bump.
Okay.
And then often after some kind of minor injury or irritation, it develops into a larger granulomatous ulcer.
Okay.
The edges of these ulcers are typically well defined, but a key thing here is that it doesn't heal on its own, and it can often lead to pretty significant scarring if it's not treated. So unlike syphilis, where the initial ulcer disappears, this one persists.
Right, okay.
And can really cause some damage over time.
Okay, so we've covered kind of what you might see, what you might feel.
Yeah.
But how do they suggest we figure out which one it is?
Right.
What kind of investigations do they recommend in these guidelines?
So they list two main investigations: the VDRL test, which stands for Venereal Disease Research Laboratory Test,
right,
and the TPHA, or the Treponema pallidum hemagglutination assay.
Okay.
And interestingly, for both of these, they say if available, which is, it just sort of highlights the reality of different healthcare settings and situations.
And these are blood tests.
Yes, they're blood tests that essentially look for antibodies that your body makes in response to the syphilis bacteria.
Okay.
So they're not directly detecting the bacteria itself.
Right.
But, the presence or the levels of these antibodies can indicate, whether there's an active or a past infection. Yeah. So given that, getting immediate, very specific testing might be a challenge.
Right.
It seems like there's a particular strategy that the guidelines kind of put forward in terms of the initial treatment.
So what are the main objectives when it comes to actually treating these ulcers?
So they outline a couple of key objectives. First, with herpes simplex, the goal is to treat those small ulcers and the vesicles, those blister-like lesions,
right,
especially if they're recurring.
Right.
And then, and this is really crucial, the initial management of all genital ulcers should concurrently target herpes simplex, syphilis, and chancroid.
At the same time.
At the same time. So basically, because, getting a definitive diagnosis might take time or resources might be limited, they're saying start with the treatment that covers those most common and potentially serious causes.
So you're kind of casting a wide net initially.
Exactly. While
you're waiting for the more precise diagnosis.
Precisely.
Okay. And it's aside from the medication themselves, is there any kind of general non-drug related advice in the guidelines?
Yeah, they actually give one very straightforward piece of advice, which is to keep the lesions dry and clean.
Oh, okay, yeah.
Which, simple hygiene, but it can make a huge difference.
For sure.
In terms of preventing secondary infections and just, allowing those ulcers to heal.
Absolutely. Okay, so let's get into the specifics of the medication. Starting with herpes simplex, what do the guidelines recommend for treatment?
So for an initial outbreak, the guidelines give us a couple of options for oral acyclovir.
Okay.
Either 200 milligrams taken 4 to 6 times a day for 7 to 10 days.
Okay.
Or 400 milligrams taken 3 times a day for the same duration.
Got it.
Now, for people who have both herpes and HIV, the dosages are a bit higher. So either 400 milligrams 3 times a day or 800 milligrams twice a day.
Okay.
Also for that 7 to 10 day period. So I guess the different dosages and the durations reflect how the medication's actually working against the virus.
Yeah, makes sense. And then what about if someone has a recurrence? Because we know that's common with herpes.
Yeah, absolutely. So for those recurring episodes, the treatment's typically shorter.
Okay.
They give us 3 options, either acyclovir 400 milligrams 3 times a day for 5 days.
Okay.
Or 800 milligrams twice a day for 5 days.
Oh, okay.
Or even shorter, 800 milligrams 3 times a day for just 2 days.
Oh, wow. Okay.
So much shorter duration for recurrences.
And the guidelines also mention suppressive therapy for individuals with HIV who are having those frequent outbreaks.
Right.
So what does that involve?
Oh, right. So for those individuals, they recommend oral acyclovir again.
Okay.
At a dosage of 400 to 800 milligrams, taken 2 to 3 times daily for a much longer period.
Okay.
They say anywhere from 2 to 6 years.
Oh, wow. Okay.
So it's a much more involved long-term management approach.
Right, to really try to suppress those outbreaks from happening.
Exactly.
Okay. Let's move on to syphilis. What are the go-to treatments and the alternatives?
So the primary treatment for syphilis, according to these guidelines, is a single intramuscular injection of benzathine penicillin G.
Yep.
And the dose is 1.2 million units given in each buttock. So a total of 2.4 million units.
Okay.
Stat all at once.
Wow. Okay. And is there an alternative?
There is an alternative, which is procaine penicillin aqueous, which is also given intramuscularly
Okay.
by deep injection. And it's 1.2 million units daily for 10 days.
Okay. And so I assume that penicillin is kind of the first choice there.
Yeah. I mean, penicillin is really effective against syphilis.
Yeah.
It's been used for ages.
Yeah.
So that's the preferred option unless there's an allergy.
And what if someone does have a penicillin allergy?
Right, which is not uncommon. So for those folks, they provide alternative oral medications, doxycycline at 100 milligrams twice a day for 14 days, or tetracycline at 500 milligrams 4 times a day, also for 14 days. And it's worth noting that those alternatives require a longer course of treatment compared to the penicillin injections.
Okay. And what about for pregnant women?
Right.
Because obviously treating syphilis in pregnancy is so important. Are there any specific recommendations for pregnant women who have a penicillin allergy?
Yes. For pregnant women with a penicillin allergy, they recommend erythromycin 500 milligrams 4 times a day for 14 days orally, or azithromycin 500 milligrams once daily for 10 days, also orally. And yeah, you're absolutely right. Managing syphilis during pregnancy is really critical to prevent that transmission to the baby.
Absolutely.
Yeah.
Okay, let's talk about chancroid. What treatment options do they recommend for that?
For chancroid, they give a few different options, both single dose and multi-day.
Okay.
Ceftriaxone as a single intramuscular injection at 250 milligrams.
Okay.
Or azithromycin, a single oral dose of 1 gram.
Okay.
Alternatively, there's ciprofloxacin orally, 500 milligrams twice a day for 3 days.
Okay.
Or erythromycin orally, 500 milligrams 4 times a day for 7 days. So I think having these different options, including those single-dose regimens, can really be helpful to make sure that people are completing the treatment.
It's interesting to see those different options for chancroid. Okay, so lastly, we had the granuloma inguinale. And while they don't give us specific treatment details in this excerpt, the fact that it doesn't heal on its own and can cause a lot of scarring, I mean, that really underscores the need to get it treated, right?
Absolutely, yeah. And while we don't have the specifics here, the guidelines would, of course, have recommendations for granuloma inguinale,
For sure.
given that potential for damage.
So we've really covered a lot of ground here.
We have.
We've talked about the initial causes, the symptoms, how to potentially tell them apart, the investigations that are recommended, and then we went into detail about the treatments for herpes, syphilis, and chancroid.
Right.
For you, our listener, what would you say is the most important thing to take away from all of this information, from this deep dive into the Ghana Standard Treatment Guidelines on this topic?
You know, I think the key takeaway is that these guidelines offer a really structured and evidence-based approach to managing a group of conditions that can, present with similar symptoms.
Right.
They carefully consider those different potential causes, the ulcers, they suggest some specific ways to investigate them, and then they lay out these very detailed treatment plans,
Right.
including these important adjustments for folks with HIV or for pregnant women who have allergies. And I think that strategy of starting with a broad treatment approach is really, really smart, especially in situations where you might not have access to testing right away.
Absolutely. And, I think it's so important for you, our listener, to remember that while we've gone through all these details, this should never take the place of getting proper medical attention.
Oh, for sure.
If you are experiencing any of these symptoms.
Absolutely.
So this is meant to inform you, to give you background.
Right.
But ultimately, you need to see a healthcare professional for a diagnosis.
Yeah, 100%.
And a treatment plan that's specific for you. So I guess if someone is experiencing these symptoms, the most important thing based on these guidelines is to seek medical attention and to seek it promptly.
I couldn't agree more.
I mean, it's okay to be informed. In fact, it's a really good thing, and it can help you have better conversations with your doctor.
Absolutely, yeah.
But you really need that expertise to figure out what's going on.
Right.
So as you kind of think about what we've discussed today, think about this. How do standardized treatment guidelines like these impact public health on a larger scale? How do they potentially lead to more consistent, more evidence-based care across different healthcare settings and for different populations? It's a really interesting thing to ponder.
Yeah, it is.
How these guidelines actually play a role in healthcare systems all over the world.
Thanks for joining us for this deep dive.
Thanks for having me. It was a great conversation.
Appreciate it.
Take care.